which is, corrupt actually, and, and having lots of problems. They are spending on health more than Kuwait, which is one of the biggest oil producing country. So health expenditure doesn't only go for buying drugs and machines and sending people to have, abroad, علاج بالخارج. The money that goes to preventive programs, money that goes for educators, these are the money that we need that actually cost a lot, but the government don't look. And most of the officials, they only look at their feet when you talk about diabetes and prevention. They don't know that complications means a lot of money. When you talk about, educators, preventive programs, diabetes scores, screening programs, there is no money for that. And that's the reason we have problem with the high prevalence of diabetes. This is how much Kuwait spent in the diabetes-related health care. This is from the IDF. This is comparing 2010 to 2030, around $374 million goes for diabetes, either direct or indirect cost, and that's going to be around 900 million. And how much of that money we can actually save when we go through, prevention and actually screening our population to prevent these diabetes things. Death attributed to diabetes, you can see it's very high in the Kuwaitis, and the rate starts from age 60 as in the world, according to the International Diabetes Federation. So this is a very serious disease that's killing us. Obesity is one of the issues in Kuwait. When you talk about diabetes, always obesity comes in hand. I know some of our colleagues will not like these pictures, but that's what's written in the newspapers, just to show you. And we know that obesity and diabetes go hand in hand in terms of their prevalence. So, and that's telling us the relationship between the two together in terms of the metabolic, what we call the metabolic syndrome. This is just to show you what's in the world, who's the leanest and who is the fattest. And you can see here for Switzerland, Hungary, and Norway are from the leanest, and Yugoslavia, Greece, Romania, and England are probably one of the fattest population. Children and obesity is one of the issues that always come to our mind. We know that diabetes in children is coming to our clinics nowadays and to our food. This is a study from the IMRON done in Kuwait, 2007, and they looked at obesity among Kuwaitis between 10 and 20 years. And you can see here the rate from age 14 and 20 years, around 22 to 25.7%, which is considered the high rate of obesity. If you look at age of 13, and again, the same thing, it's very high in both male and female. But look at age 5 to 9, it's 13 and 15% in boys. And this is the most serious finding in this study, 5 to 9 years old. And the reason is because at this age, parents feed the children. It's not teenager or elderly man who actually go and eat whenever he likes. It's the parents' issue. So this is a problem in the family. The family actually feeds the children wrongly. They make them, go to fast foods. It's easier not to cook. Orders, delivery, availability. So واجبك was أعطيك وجبة والكلام هذا اللي always we hear it. Using these fast food as an easy way out to go out and leave your children. Money is available, drivers available, delivery is available, and decision at home is very bad in terms of healthy eating. That's why obesity. And you look down here, this is a picture that's showing how our children is now under stress between the burger and the apple. And look at there, this is a Kuwaiti children, maybe in the 40s, look all thin. And look at the children when you go and take your children from school. Lots of, bellies you can see. Again, this is in Kuwait, a questionnaire study recently in 2015, looking at, female children, BMI, and they asked them about, does your children have an overweight, obese sibling? And, it's very significantly, a very significant finding because, if they have sibling, it's one of the risk factors. How often does your child eat out outside as a fast food restaurant during the week, also a significant risk factor for obesity. In men and children, male children, same findings, and also how many hours that your child watch or spend TV, also very significant risk factor for obesity in children. So this is one of the things, sometimes if you want to get rid of your child, give him the iPad or open the TV for him and let him sit there for a few hours, and that's one of the reasons actually that cause obesity. And this is one of the things that we see all the time around the attack of fast food everywhere, near the schools, actually sometimes inside the schools. And not long time ago, we had also in the Faculty of Medicine fast food, as Dr. Fahad remember, and they had hard time to remove it, the Faculty of Medicine, because it comes from Qadiya, not from the faculty anyway. So, you know, even in the House of Medicine, we had fast food. Everywhere we have fast food. Around schools, around our homes, fast food is actually everywhere. One of the challenges we see with this disease is that it's very complex. It's not, you know, simple hyperglycemia as you see it. Diabetes have multiple pathophysiological defects that we see. Long time ago, when I was in medical school, we only remember, you know, insulin resistance and insulin insufficiency. But now we have many other, you know, pathophysiological changes. We have incretins that are, you know, opening a big, you know, opportunity for medicine. You have changes in the brain related to diabetes. We have also, how many minutes we have? 5 minutes. 2? You said 5? Okay, it's okay. Renal issues that happen on top of the increased hepatic glucose production and insulin resistance. Okay. Before we have metformin, sulfonylurea, and insulin. Insulin from 1920s, sulfonylurea and metformin from 1950s, 56 to 55. Now we have all these things available to our treatment, in our armamentarium, and our some of them are less, like TZD, but the rest we have most of them available for us for treatment. I'm not going to go that because of the time issue. Now this is again showing all these medications that are available to us in the treatment diabetes, and the latest ones available are SGLT2 inhibitors, which actually release the glucose in the urine, causing weight loss and also hypoglycemia and decrease in the hyperglycemia. Many drugs are coming. This is a big field for the pharma to actually look for new medications. You have lots of new medications coming in the pipe that are actually going to be available maybe in the next 10 years. Care providers, most people with diabetes are not reaching their goals. Is it because of us or is it because of the patient? We know that if you look at them all, you know, foot exam, annual exam, blood pressure, total cholesterol, HbA1c, we're not doing well overall in controlling our patient. And the cycle of frustration between us and the patients, we always as doctors blame the patients, and the patient blame the doctor. And there is nobody to cut the circle. And this is actually a big problem in the field of medicine, and that also need to be taken care of. There are lots of patients' issues that we don't think about. Our patients, we tell them to take medicine, insulin injections, but we don't know what they do at home, the stresses that they have. And we don't have the expertise as doctors to actually deal with that, and that's also one of the failures that we have. The chronic care model for patients, we call for chronic care model, we call for teamwork, not only physician, educator, you know, helper, and all of these, but la hayata liman tunadi, most of the government don't understand even this concept. Care, you know, specialist input lead to better care in general. So if you not only rely on a doctor as a teamwork, we know that actually you're going to get better outcome as is shown in many studies, and this is one of them. Goals to improve diabetes, promote active self-management, enhance psychological care, which is actually one of the most important things, enhance communication between people with diabetes and healthcare provider, promote communication and coordination between healthcare professionals, reduce barriers to effective therapy, which are a lot. The strategies we need: raise awareness and advocacy, educate and mobilize people with diabetes, train healthcare providers and enhance their competencies, provide practical tools and systems that we always need, drive policies and healthcare system change, and develop psychological research in diabetes, which is also something in our area that's not seen. Thank you very much.
Thank you, Dr. Walid. Our next speaker is Professor Antoine Lensing from Amsterdam, Netherlands. He's Professor of Vascular Medicine, Academic Medical Center in Amsterdam. He'll be presenting on updates and special considerations on venous thromboembolism prophylaxis, a very hot topic, and we look forward to hearing him.
Thank you very much, Mr. Chairman. Thank you very much for having me here in beautiful Kuwait. This is my second time now, and I feel already a little at home, I have to admit. In this presentation, I would like to present you data with the new oral anticoagulant rivaroxaban. Rivaroxaban is one of the 4 new oral anticoagulants that are on the market now, and we have now quite some experience with those drugs, and I would like to share the results. First, I should know how I can go to the next slide. How do I do that? With this one, eh? Yes, I see it. I see. Okay.
And you have the mouse as well to.
Yes, I see. I can handle it like this. So venous thrombosis, venous thromboembolism is a disease that occurs relatively frequent. Every per 100 patients per year, per 1,000 patients per year, we have 1 or 2 new cases. If we do not treat those patients adequately, then we have a big problem, namely that 20 to 30% of those patients will have a recurrent venous thromboembolic complication, and that is what we aim to prevent. And we do that with the use of heparin and vitamin K antagonists. And as you know, we can do a very good job. We reduce recurrences from 20-30% without treatment to only 3% with treatment. However, warfarin, heparin have disadvantages. Warfarin has a slow onset of action. Heparin is needed before warfarin can be given, and altogether there is a big need to change treatment into a far more easier treatment that preferably is also safe and very effective. Here we have rivaroxaban. Rivaroxaban is a factor Xa inhibitor. It is oral. It has an oral bioavailability that is enormous. So what you give the patient, that is what will be active as well in a very reliable manner. A rapid onset of action. The drug, although it is given orally, is as quick, as fast as injection with low molecular weight heparin. Actually, it is a oral low molecular weight heparin. The half-life is 7 to 11 hours, so that means you can give it once daily, and the drug is cleared by the kidney. Only 1/3 of it is cleared by the kidney. That means even when kidney function goes down, you hardly will have any accumulation of drug. Then we do have a very small in exposure with varying body weight. So somebody of 50 kilogram or somebody of 150 kilogram, the exposure is almost the same, since rivaroxaban exposure depends mainly on the circulating volume. Then we do have a very wide therapeutic window: 20 milligram, 30 milligram, 40 milligram, 60 milligram. All those strengths have shown to be effective and not associated with increased in bleeding. And then finally, rivaroxaban has a very limited absorption at the end. When a patient is taking more than 50 milligram, which is 3 tablets of normal treatment, then the absorption is really kept at that level. So a patient cannot take more rivaroxaban than required because it is simply not absorbed. So it is not a good drug to commit suicide for. And in the emergency room, you simply do not have to deal with a patient who is taking 10, 20, 30 or 40 tablets at once because there is no absorption. So rivaroxaban cannot be given in a fixed dose without any heparin to replace low molecular weight heparin and warfarin for the treatment of deep vein thrombosis and pulmonary embolism. And we tested that in the Einstein DVT and PE studies. Almost 8,000 patients, as you can see there, were treated with rivaroxaban or standard of care. Standard of care was given with enoxaparin for at least 5 days, followed by VKA. Patients were treated for 3, 6, or 12 months as assessed locally by the investigator, and rivaroxaban was given without any use of heparin, just from the start on oral rivaroxaban only, 50 milligram twice daily for the first 3 weeks, followed by 20 milligram once daily for the period thereafter. And during this period of 3, 6, and 12 months, we looked for recurrent vein thrombosis, major bleeding, mortality. And here are the results for efficacy. As you can see, recurrent venous thromboembolism occurred less frequent with rivaroxaban. Also with enoxaparin, the rate was not very high, as usually seen between 2 and 2.5 cumulative incidents, but clearly showing in this large study of 8,000 patients, non-inferiority rivaroxaban is as good as. The clot size and recurrence is also an important issue. We repeated CT scan in 264 patients who had a PE. At 3 weeks, they were treated with rivaroxaban or standard of care, and at 3 weeks, fixed dose treatment with rivaroxaban was as good as adjusted dose enoxaparin and adjusted dose VKA. Namely, 44% had complete resolution already, 45 partial resolution, and approximately 10% of patients had no change. Also, we found that of the rivaroxaban patients who had a small clot, a popliteal vein thrombosis, or a small single lobe pulmonary embolism, or an extensive clot, it didn't matter. As you can see, 800 patients here, 800 patients here had a small clot. Recurrence rate are the same. Intermediate clot, 2.4 and 2.6% had a recurrence. And here with a large clot, also here, 2.3 and 2.1% had a recurrence. So it doesn't matter. Fixed dose, oral rivaroxaban, 1 tablet a day, is as good as adjusted dose vitamin K antagonist. And here are the data for bleeding. What about the safety? We do not monitor it, so are patients having a higher rate of bleeding? The answer is no, the opposite. With rivaroxaban, bleeding is significantly lower than with standard of care. As you can see, the cumulative incidents start to separate already in the first weeks from standard of care with enoxaparin, and that continues to rise, whereas here we see a stabilization over time. But let me show you on this slide that is better to understand. We had 40 patients with rivaroxaban who had a major bleeding and 72 in the standard of care group. And again, that is the group where the INR was monitored, and with rivaroxaban that was not the case. And here we found an almost 50% risk reduction in bleeding. What bleeding are we talking about? Fatal bleeding occurred less often with rivaroxaban as compared to with enoxaparin. Bleeding in a critical site, that was retroperitoneal or intracranial or pericardial bleed, occurred in 10 patients with rivaroxaban and 29 patients with standard of care, again monitored by the INR, and a major bleeding that was associated with a fall in hemoglobin or needed transfusion was seen in 27 rivaroxaban-treated patients and 37 standard of care. So bleeding is not only less frequent with rivaroxaban, but also the severity is less. Less fatalities and less critical site bleeding. There is no antidote for rivaroxaban. That is what most doctors in the world are saying. There is no antidote. It is so dangerous. Well, tell your patients first that the risk of major bleeding is reduced by 50%. And if you have a major bleed with rivaroxaban, tell your patient that the bleeding is less severe. And then tell the patient that is how they present to the hospital is far less of a challenge than a bleeding with vitamin K antagonists like warfarin. Here you see the data. Patients presenting to the emergency room with a major bleeding had in 40% of the cases of rivaroxaban a controllable bleed, and that was 21% with warfarin monitored by your INR. Not serious, but required measures to control the bleed. The same serious major bleeding at presentation, 15% and 32%. And that makes up for a highly significant increased severity with standard of care. So how often do we use the usual things to control bleeding? With rivaroxaban, fresh frozen plasma was only used 4 times, and it was used 11 times with enoxaparin VKA. Prothrombin complex, 2 times with rivaroxaban, 9 times with enoxaparin and VKA, and recombinant factor 7A only 1 time. So we also do need less prohemostatic measures to control bleeding. So at the end, without a specific antidote, we have less bleeding, less severe bleeding, and actually we can control the bleeding very well in the emergency room. So let's focus now on patients who are fragile. Patients who are fragile, we are afraid to give rivaroxaban in fixed doses without monitoring. And here you can see if a patient is fragile with rivaroxaban, the recurrence rate is 2.7. Recurrent venous thromboembolism 2.7 and standard of care 3.8. So it's doing actually very well. In non-fragile patients, it is 1.9 and 1.9% respectively. But look here, major bleeding with rivaroxaban in fragile patients who are old, have a poor kidney function, or have a very low body weight. We see that the major bleeding rate is only 1.3%, and it increases to 4.5% with standard of care that you monitor with the INR. So doctors who are saying, I give rivaroxaban only to healthy patients, but not to patients who are vulnerable or at risk as bleeding, well, based on this data, you might reconsider your decision. Renal function. Let's have a look here. This is recurrent deep vein thrombosis with rivaroxaban in a patient with a normal renal function and a mild and a moderate renal impairment. And what do we see is that in the rivaroxaban group, there is an increased risk of recurrent VTE with declining kidney function. 1.8, 2.4, 3.3, and that's a p-trend 0.001. That means renal impairment is a risk factor for recurrent venous thromboembolism with rivaroxaban during treatment, but also with standard of care, 1.9, 3.1, 3.4. So should we treat patients with renal impairment with a lower dose of rivaroxaban? As you see this high risk of recurrence in patients treated with 20, that is very doubtful. Let's have a look at the bleeding in patients with renal impairment. And here you see in rivaroxaban treated patients, 0.8%, 1.4%, and 0.9% had a major bleed. There is no increased risk with declining renal function, whereas for standard of care, we have 1%, 3%, and 4%. So again, if you have a patient with renal impairment and you say, I prefer to treat this patient with warfarin because I can fine-tune it with the INR and I do not give rivaroxaban because it is fixed dose, you might make a wrong decision. Major bleeding in patients who have been treated concomitantly with NSAIDs or with aspirin is increased with both rivaroxaban and enoxaparin. Look, if a patient is treated with rivaroxaban and you add an NSAID on top of that, we have an increased risk, 2.5% higher. NSAIDs are very scary. You can buy them around the corner in the drugstore. Very scary drugs, increasing bleeding risk. Not only with rivaroxaban, but also with enoxaparin. Look, from 2.7 to 8.4. The same occurs with aspirin. No aspirin, 1.6 events per 100 patient years, increasing to 3.3, and with standard of care, the same, from 2.9 to 6.9. So please tell your patients to stay away from NSAIDs during anticoagulant treatment. Cancer. We treat cancer patients with deep vein thrombosis and pulmonary embolism, preferably with low molecular weight heparin. But, as you know, many patients do not want to be treated with low molecular weight heparin only, or they do want to stop after having been treated for some time. What to do? Well, those patients were part of our program in the Einstein DVT and PE study. And here are the results. In patients who had active cancer, in the rivaroxaban group, the recurrence rate with fixed dose rivaroxaban was 4.5 as compared to 6.6%, and hazard ratio of 0.67 and not significant. However, major bleeding was reduced from 5% in the standard group to 2.3% in the rivaroxaban group for a 60% risk reduction that was significant. Let's have a look to what happened at patient with cancer and renal impairment. You are now familiar to this slide. With rivaroxaban, 2.4% major bleeding if normal kidney function, 2.2 and 2.1 with a creatinine clearance below 50. But with standard of care, we go through the roof, 2.7, 5, 13%. Again, the most vulnerable patient with cancer and renal impairment, in whom you might say, well, maybe I do not give rivaroxaban to those patients. Those might be the patients who can benefit most. In conclusion, patients treated with rivaroxaban for symptomatic deep vein thrombosis or pulmonary embolism, we found non-inferiority versus standard of care. With enoxaparin VKA, we found a 50% risk reduction for major bleeding. We found a very consistent effect on efficacy and safety, regardless of gender, presence of comorbidities, and that was all done with the single drug approach of rivaroxaban without any heparinization and, most importantly, without any monitoring of the anticoagulant effect. I thank you very much.
Thank you very much for this nice presentation. Please come over here and we'll take questions at the end. Thank you.
The third speaker will be Dr. Fuad Al-Ali. He's a professor of medicine and consultant gastroenterologist in Mubarak Al-Kabir Hospital. He's a graduate of Kuwait University. He completed his postgraduate training program in Miami University, and after that he was specialized in gastroenterology in Texas. He's currently a consultant gastroenterologist in Mubarak Al-Kabir Hospital, and he has more than 40 publications, mostly on viral hepatitis. His talk will be Advances in Hepatitis C. Professor Fuad.
So thank you very much, Kuwait Medical Association, for giving me this opportunity to talk to this very distinguished audience. My talk will make every speaker in this room and previous speakers envious, because what has been accomplished in the area of hepatitis C, I think, exceeds whatever has happened in medicine in the last 10 years. So it is very exciting time to be a hepatologist these days. Hepatitis C, as you know, affects 150 million people around the world. 10 years ago, I would have told you 170 million. But the incidence of hepatitis C has declined over the years thanks to the measures that have been taken at blood banks and infectious control measures in the hospitals and so on. Nevertheless, the disease burden has not decreased, and I'll explain to you why. The Middle East is unique when it comes to hepatitis C because it harbors the highest prevalence in the world. If you take Egypt, for example, the prevalence ranges between 10 to 15% in the entire population. That is compared to 1 in 1,000 to 1 in 100 in other places around the world. So, and that of course reflects upon the prevalence of the disease in neighboring countries because as you know, especially in the Gulf area, there is a large Egyptian population, but even in the native population, say for example, the Syrians living in the eastern province of Syria, they have very high prevalence of hepatitis C, and I think countries like Saudi Arabia, Iraq, Yemen, and Sudan have very high prevalence. Hepatitis C exists in at least 60 major genotypes. And again, the Middle East is unique in that it has a distinct genotype. The most prevalent genotype around the world is genotype 1, followed by 2 and 3. But in the Middle East, the commonest genotype in Egypt, Kuwait, Saudi Arabia, and Syria is genotype 4. As you might know, genotype, HCV genotype, is a major determinant of response to therapy. Again, you are familiar with the natural history of hepatitis C. Hepatitis C differs from hepatitis B in a very important aspect, and that is if you get infected with hepatitis C, you have a very high chance, reaching 70, maybe 80% chance of becoming chronically infected. Whereas as an adult, if you get infected with hepatitis B, you have a 95% chance of clearing the virus. So there is a high propensity for chronicity. And if you are chronically infected, you have a higher risk of developing cirrhosis, liver failure, hepatocellular carcinoma, and of course, this might require liver transplantation and significant mortality. The hepatitis C is generally a slow virus in terms of inducing damage. However, under certain circumstances, cirrhosis can develop at a rapid pace. For example, if you acquire the infection as an elderly person, progression to cirrhosis is rapid. Also, consuming alcohol, being infected with HIV and HBV accelerates disease progression. So when we talk about disease burden, we're talking about cirrhosis and hepatocellular carcinoma. And as you see from this slide, still hepatitis B is the commonest cause of cirrhosis and hepatocellular carcinoma around the world. But hepatitis C exceeds alcohol in terms of causing hepatocellular carcinoma and cirrhosis. Now, the traditional treatment for hepatitis C has been injections called interferon, you're familiar with that, and tablets called ribavirin. Until 2013, that was the mainstay of treatment of hepatitis C in our patient population. The treatment was associated with numerous side effects. The patients would hate you because most hepatitis C patients are asymptomatic, but they are at risk of developing liver failure and symptoms later on. So here you bring somebody who feels well, and you give them a horrendous medication like interferon, which causes fever, myalgias, headache, hair loss, bone marrow toxicity, rash, and ribavirin, which causes hemolytic anemia, fatigue, nausea. So patients really hate it, and at least 10 to 15% will drop out when you treat them with this combination. The duration of therapy is 12 months for most patients, which is also pretty long. The cure rate varies between 30 to 70% based on genotype and the degree of fibrosis and so on. But in certain population, it may be less than 10%. So if somebody has been treated with interferon and failed therapy, repeating the therapy is very, very unlikely to result in a cure. It's contraindicated in many settings. For example, if the patient has well-established cirrhosis with decompensation, that's not a good patient to treat. They will have a lot of side effects, and the chances of response is small. It is not cheap. It costs about, in Kuwait, it costs about 4,000 KD. Now, the treatments I'm going to tell you about, which have evolved since 2013, are different from the previous medications in many important ways. First, the duration of therapy in most patients is 3 months. There are some exceptions when we treat for 6 months, but the majority of patients need to be treated for 3 months. Second, there are tablets, no injections. People hate injections, so cure rate, more than 90%. Again, it's very important to stress this point. We're talking about cure. Hepatitis C is the only chronic viral infection that can be cured. And that's the beauty of and the rewards when you treat such patients. Side effects are mild or none, as I will show you in the coming slides. The cost is a drawback. The cost is expensive. There are several combinations, but they range between 15,000 KD to 22,000 KD. That might sound very expensive, but you always, when it comes to expense, you have to take it in the right context. For example, if you treat inflammatory bowel disease, and ulcerative colitis, Crohn's disease, with biological agents, that costs about 7,000 to give somebody Humira or Remicade. So that's 7,000 KD. That has to be taken indefinitely, basically. It leads to some remission for a year or two, and then patients develop resistance and develop antibodies, and and you have to switch them to something else. So you have to think of cost per cure, not cost per year or per dose. So if you're curing somebody for 22,000 KD, whereas you're spending much higher cost to control another disease like inflammatory bowel disease, I think it's clear where the balance tips. I think it will tip towards something like the new medications for hepatitis C. So the cost has to be thought of in terms of cure, not in terms of how long and so on. So what brought on this revolution in the treatment? How come we can cure hepatitis C? Hepatitis C is a good example of how bedside research can lead to dramatic and revolutionary treatments. So this is the life cycle. This is the life cycle of the virus, hepatitis C. The virus here attaches itself to special receptors on the surface of the hepatocytes. It undergoes endocytosis. The viral RNA is released by a process of uncoating. The viral RNA undergoes translation to form the viral proteins. Then the RNA undergoes replication mediated by RNA polymerase. Then the proteins and the RNA, the new RNA, are combined and assembled again to generate new viruses, and then these new viruses leave the hepatocyte to infect other hepatocytes. So that's the life cycle of the virus, and it has been found the proteins that mediate these three processes, translation, replication, and assembly, have been identified clearly. So NS3 and S4 proteases are involved in the first process, and NS3 protease inhibitors are an important part of the regimen in treating hepatitis C. Another protein or set of proteins are the NS5A proteins. These letters NS5 and NS5A and B refer to the viral genotype, the genome. So there are different regions, NS3, NS4, NS5A, NS5B. These are regions, the viral genome. Each region codes for a protein. So the NS5A proteins mediate viral replication and assembly. NS5B proteins refer to the polymerase. So inhibiting any of these proteins will lead to viral inhibition of viral replication. So it all started in 2011. The first wave of NS3 protease inhibitors were introduced. They included telipravir and pocipravir. And these have become now obsolete because although they were effective, but they only were effective against genotype 1. They were not effective against other genotypes. Also, they had a low barrier to resistance, and they were associated with numerous side effects, so they have become obsolete. The second wave included semipravir, paratipravir, and several others, but the ones that have been licensed are semipravir and paratipravir, and the second generation of protease inhibitors include crazipravir, which has been licensed just less than 2 months ago. When we take the nucleotide analogs for the HCV RNA polymerase or the NS5B protein inhibitors, they include the most potent of which they include sofosbuvir, a very potent inhibitor of viral replication, and then they include some other ones, but the ones that is licensed is sofosbuvir. This one is pan-genotypic. It is effective against all genotypes, and it has a high barrier to resistance. Then the non-nucleoside inhibitors of NS5B region, and these include baclabuvir. It's not licensed yet, but the one that is licensed is the zipuvir at the other column. The zipuvir is licensed and is effective against genotype 1 only, and has low barrier for resistance. When it comes to NS5A inhibitors, the first generation include the declatesvir, ladibesvir, and ombetesvir, and they are all licensed, and they are effective against genotypes 1 and 4, with some variable efficacy against other genotypes, low barrier for resistance. Elbesvir has been recently licensed, is pan-genotypic, and has a slightly higher barrier for resistance. Now, in 2014, as you know, when we talk about antiviral therapy, you have to use these therapies in combination, because using monotherapy will lead to resistance. And this is the same model that is used in treatment of HIV. So in 2014, we had sofosbuvir, semipravir, and declatesvir used in combinations with interferon. You remember the injections? But in 2015, we stopped using the injections, and now we use all oral combinations. One of the popular combinations is sofosbuvir plus ladibesvir. It's 1 tablet a day. It covers genotypes 1, 4, 5, and 6. There is another combination, several tablets per day. It includes ombetesvir, paratipravir, ritonavir in 1 tablet, and dazipuvir in another tablet, effective against genotypes 1 and 4. Sofosbuvir plus the declatesvir, 2 tablets a day, are effective against all genotypes. In 2016, we have a new kid on the block, elbesvir, which is basically grazopravir. It has been licensed. It was licensed on the 28th of January of this year. So let me show you some historic perspective. So in the old days, in the 80s, we used only interferon with a success rate of only 7 to 11% cure rate. And now we are talking about 93 to 100% cure rate for genotype 1. Genotype 1 was considered in the days of interferon as very difficult to treat genotype. These are some trials, ION 1, 2, and 3, pertaining to sofosbuvir, ladibesvir combination, plus or minus plus or minus ribavirin, and again you see the cure rates of 99%. Amazing. So now it's very rare to have somebody not responding to therapy and not being cured. Again, another study in people who failed protease inhibitors, again, very high response rates. Now these slides will become boring because it's all 90%, 98%. That's why I gave you the summary in the beginning. So again, genotypes 2 and 3. Genotype 3 now is considered the most difficult, not genotype 1. And you see a slightly lower. So now we are so pampered that if the cure rate is less than 90%, we say it's difficult to treat. In the old days, when people were cured, even when it was 40%, we'll say this is a good medication. Sofosbuvir ribavirin for genotype 2 and 3. Again, cirrhotics, genotype 3, difficult to treat. However, when the clatisvir is used with sofosbuvir, we go back to the 94, 97, 96 response rate, especially when we extend the therapy to 6 months. Genotype 4, our genotype in the region, is easy to treat. All combinations basically work for genotype 4. Again, different combinations, sofosbuvir, ledipasvir, paratipravir, ombitesvir, very high response rates. This is the most recent medication licensed just in January, late January. And so it's a combination of a protease inhibitor and an S5A inhibitor. Again, not to bore you, it's licensed only for genotypes 1 and 4, and it may be licensed later on for other genotypes. And as you see, very high sustained virological response. Side effects, very, very safe, very, very excellent safety profile. Maybe fatigue, a little bit of nausea. If you combine it with ribavirin, you may have a problem with anemia. But we're trying to get rid of ribavirin in most patients. Adding ribavirin helps us give shorter courses. The drawback, the major issue is drug-drug interaction. So whenever we want to start these therapies, we have to look at the drug list and adjust the medication and avoid certain medications, but it's doable. Again, drug-drug interactions have to be carefully looked at. Remaining challenges, cost, we talked about genotype 3 now being addressed with the clatisvir, getting rid of ribavirin, we're going to get rid of it. Renal failure, it used to be, the other medications were contraindicated, but now with the introduction of elbasvir and crasipravir, it is safe to be used in renal failure patients. Then there are tiny patients, 1, 2, 3, 4% of patients who do not respond. This will be a problem. We'll have to wait and see. So my final point, now with these very effective medications, I think there is an opportunity to eliminate rather than eradicate hepatitis C. This is a mathematical